I'm going to start it. Welcome everyone. We're going to thanks for attending. I'm going to talk about management of basically cervical reduction, but I'll also throw in a bit about recognizing features on the cervical X-ray and where to put cones, calipers, and how to put them on. We've seen a run of absolutely horrific looking cones, calipers the last 6 months, and obviously the course is way overdue. So hopefully we'll have a better understanding. Just some context. Just put the slide. Failure of mouse keys. There you go. Okay. This is a lawyer who spoke at our Congress about 3 years ago. He's a trust lawyer, 58-year-old guy. Was mountain biking in January 2015 in Yonkers. Tried to cross a bridge, bumped and fell on his head. He was moving his legs at the scene and was transported to a top private hospital in Cape Town, the northern suburbs, and he was assessed as this is injury. You can see he's got a cervical fracture dislocation, incomplete neurology. At 8 o'clock, his legs are 4 out of 5 power. 11:30, 2 out of 5 power. He's finally transferred. They phoned me around that time. They couldn't reduce the neck, or they didn't know how to do it. At 2 o'clock, he got to me. I was in the ICU. I pulled his neck straight in 15 minutes. He's 0 out of 5. And unfortunately, remains quadriplegic. So it's a very poor neurological outcome for someone who's had 4 out of 5 power on the scene. So is this preventable? Would earlier reduction helped? And is cervical reduction limited to specialist or level 1 trauma hospitals? And I guess that's the question we'll hopefully answer. What imaging do you want? You can see he had everything. I mean, through CT, X-ray, MRI, what do you really need for a cervical injury like this? Okay, and should he have gone to urgent theatre? Is it you want to rush to theatre and do the operation as soon as possible? Is that going to be helpful? Okay, so key points, you need to make a diagnosis. History, simple. Examine your patient. If the patient's not moving his legs, he's got a spinal injury and is otherwise proven. So simple ATLS, there's nothing different about it. You want to log roll the patient. You can't feel the neck, just try to stick your hands in the back of the body. You log roll the patient, you feel an occiput to the perineum, and you do PR. To document the bulbar cavernosus, it's really important. Now, people talk about tonus. Tone is a very vague thing. It depends on various factors. You want to see if the patient's got a voluntary pinch and have a good sensation to a pin. Okay, those are two very clear endpoints to decide is there a complete or incomplete injury. Also, when you're palpating, feel for a step and a gap, and you do appropriate imaging. Okay, so these are standard guidelines. Asymptomatic patients with trauma don't need imaging. We know this. Nexus criteria: neurologically normal. You're not drunk. You don't have neck pain or tenderness. You don't have a distracting injury. These guys do not need an X-ray. Okay, you can diagnose it and exclude clinically a neck injury. Standard X-rays, AP lateral adjoint views. In many parts of the world, patients don't get X-rays. In Germany, they just do CT scan. Chris Barnard, they sort of got above, depends who's on call. The CT is great. It gives you really good anatomy. There's a lot of radiation, and you can get all the information you want with a standard X-ray. So a lot of my focus is based on the level 2 hospital with periphery where they don't have CT scans, especially in the rural areas, and we everyone needs to know how to identify injuries on the X-ray. These standard views. I believe views are a waste of time. They're not really helpful, and they're not part of your trauma views. The CT can pick up many injuries. You don't see an X-ray. helical CT is very quick. And as I said, in level 1 hospitals, it's now the standard of care, but it hasn't replaced the 3-7 views. There you can see clearly in CT, you've got a body fracture, you've got a facet perched, you've got a fracture there. So that you wouldn't really appreciate on an X-ray. MRI, you can see the discs and ligaments, you can see the cord. It's very sensitive soft tissue injury, but it can miss injuries. And you also get a false negative rate for ligamentous injuries. Unless you see a clear flavum tear or an AOL, they may be occult injuries which you only appreciate on an X-ray and a dynamic loading. So there you can see MRI, you can see you can appreciate the PLL is still intact there. There's obviously blood running underneath it. The flavum's also still intact, but there's obviously interspinous ligament disruption there. Also in the MRI, you can see the facets, they're all sitting like tiles, and over here, these are perched facets. So you can actually see the facets quite nicely in the parasurgical views. So just looking at the standard X-ray, I've seen guys morning meeting stand up and use their plot. The standard X-ray lines very easy to see, and you won't go wrong if you follow the basic principles. Okay, the lateral, is it complete? Can you see down to T1? Yes or no? This is a nice long neck. You don't always get lucky. First of all, start with the anterior soft tissue line, and there's many different definitions of where you want it to be. Rockwood agrees to the rule of 10, 5, and 15. So 10 mils over C1, below 5 mils, and below C5, 15 mils. That's a sort of easy thing to remember. What you're looking for more importantly is a fusiform swelling. So this should be a fairly consistent thickness. If you see a swelling over here, that's abnormal. This is also consistent thickness. You're looking for a fusiform swelling, and that you must draw your eye to. The next line is the anterior body line. Pretty straightforward. You're looking for steps. I see a lot of the medical students get confused by the C1 arch. They think it's a some dislocation. You're looking, it goes behind the arch, the line. Next line is a posterior body line, and running on the back of the peg. And they should be nice and symmetrical, these two lines. You want to see, you don't want to see any steps at this point. If you get a spinal laminar line, that fools a lot of people for some reason, because the facet joints seem to distract you here. So there's the line. And the easy way to find it is look for C2. C2, you don't see the facet joints so clearly. There's a clear line between the base of the lamina and the base of the spinous process. That's where your cord runs. That's important to the spinal laminar line. And I'll show you why it's important a bit later as well. And the last line is not some line on the tips of spinous processes. That's useless because they're all different lengths. You want to talk about the lines of convergence, and it just draws your eyes to spinal lordosis, as opposed to if you have a fracture, you might have segmental kyphosis. So those are the lines you look at. Other things to appreciate are your individual discs. They should be all sort of symmetrical. The vertebrae should be nice little boxes and not squashed or different shape. Looking at cranial cervical junction, you want to see your ADI. So you want to be less than 3 millimeters in an adult, up to 5 in a kid. And your peg, now, with peg, just like sort of tippet here, is a straight line going straight up from the back of C2, okay? It doesn't angle forward or backwards. It's a straight up line. And so if you get an angulation, there may be an occult fracture you're not seeing there. So the peg's a nice straight line. And then you want to see the clivus, you want to see it approaching the tip here. If you're at a big space here, you might find that the whole spine is the head's been subluxed. It's a craniocervical dissociation. And you've torn the tectorial membrane which sits over here. So you want to see that the tip, there's different lines and things, but this is an easy radiological picture to see and to remember. Sorry, this is just showing that's where the cord runs between your back of your bodies and your spinal laminar line. So there's lots of space up here for cord. So usually around the C1, C2, you don't usually have a cord injury. There's lots of space up there. You look at the open mouth view, and here you're looking at the peg. It helps with patients with no teeth, or they open their mouth properly, but you want to see the shoulders of C1 and C2 must be lined up here. And the peg, you want to make sure the peg is sort of centric. And that's the sort of outline you're looking at. Okay. If your C1 has a burst fracture, we call it a Jefferson fracture or a burst, it displaces laterally. And remember, it's held by the transverse ligaments here. So the peg has got transverse ligaments holding its lateral masses in. If it's an unstable burst, so if the transverse ligament's ruptured, it allows the lateral mass to move very far. Okay. And then you might see an overhang. If the overhang combined on both sides is more than 6.9 millimeters, then it means the transverse ligament's ruptured. That's an unstable injury. Okay? You can't, the patient's head will displace the lateral masses more, so you can't keep them in a collar. Right? After the AP, you want to look at your spinous processes. If you have a unifacet dislocation, unifacet means only one facet jump, you have a rotation of the spine above the facet. You'll then see the entire, all the spinous process above the facet move. That's abnormal, okay? You might find if you have a oblique X-ray, it's not true AP, all the spinous process on one side, you don't have this situation where above this injury level is a unifacet rotation. Looking at the facets, there's different overlaps depending on parallax and rotation, okay? So you want to see, this is a nice true lateral, where they're perfectly superimposed, both facets. And if you move, so this is just a schematic. If you rotate the neck, they move like that, okay? The whole neck can be oblique for you, the facets move like that. That's why a unifacet, you can see the rotation, that's the sort of bow tie effect you're getting. With parallax, if you depend on where you center the beam at, they'll move in this direction, okay? It's not rotation, it's just parallax. So if your beam is centered down in C7, as you go high, you'll see more parallax area, and the facets will diverge like that, but it's not rotation. It's sort of in line at the back here. Okay, so project very well, but you can see it's obviously dislocation. Now here it's the other way around. Here the two facets, you can see it's two facets here. There's a bit of parallax, but there's no rotation here. Okay. Over here I'm seeing one facet, and here's the other facet. So the rotation is inferior. So they've taken the beam parallel to the head, the patient's body is lying a bit rotated. Okay. So this is a unifacet dislocation. There's a facet here, there's a tip, and it's still in contact with this facet. That's a unifacet dislocation. Ask questions anytime if something's not clear. Once again, over here, you can see the spinous process, very nice and zoomed in. So here you can see two facets, there's a bit of parallax here, but they're perfectly aligned, there's no rotation. I'm seeing one empty facet here, and I'm seeing the other facet over here. It's a unifacet dislocation. Also, because it's a unifacet, the one facet catching, it can't dislocate more than 50%. Okay? It only goes more than 50% if both facets jump off. So that's another clue. Bifacet, you can see here, there's the inferior level, so it's a C5. There's two facets lined up here, there's no rotation, and they're empty, there's nothing above it. Both facets have jumped off and they're sitting in front of it here. You can also see there's no rotation. That's a bifacet dislocation. The spinous processes will probably line up if you can see them, a bit bifacet, so they can't see clearly, but there's no rotation. So bifacet has no rotation, more than 50%. You can have a fracture facet dislocation as well. So you can sometimes fracture the facet or the spinous processes. So here you can see there's two facets, there's very minimal rotation, it's almost nothing. Clearly both facets are jumped off here. Why do I say it's a fracture? So your anterior body line's got a step, posterior body line's got a step, spinal lamina line is almost unbroken. Okay, so that means this is disconnection between the spinal lamina here and the body. Okay, so it's your spinal lamina line. in your posterior body line. So that's the point of the spinal line. It shows you there's a posterior element fracture. So you don't need a CT to see this. It gives you a lot of information to start looking at it. There's a unifacet. So once again, with less than 50% rotation, these are two nicely superimposed facets. You can see there's a zoom. Yeah. So two nicely superimposed facets. You see one facet in contact here, the other facet's jumped off here. So it's a nice sort of bow tie sign, unifacet dislocation. Okay, so X-ray is very quick, very rapid. You can make a diagnosis very quickly in the X-ray. In fact, the radiographer should make a diagnosis for you. Next thing is early reduction. What ways do we have to reduce the neck? So you can do closed reduction or open reduction. Closed can be sedated or in theatre, anesthetic, can be manipulation, traction, gradual, rapid. Or you can do open reduction from anterior, posterior, combined. There's all different ways of reducing it. What does cervical traction do? So cervical traction is indirectly decompressing the cord. When you have a jump, when you have a dislocation, the cord is being pinched, okay? And by aligning the spine, you're decompressing it indirectly. Other reasons is to maintain alignment, prevent secondary injury, and to improve neurological outcomes. When do you put in traction? For the common things we see are C1-2 rotatory subluxation, displaced peg fractures, hangman's fractures. Which one's unstable ones, eh? Or subaxial cervical fractures with malalignment. You're maintaining, it's like a femur fracture. You put in Thomas splint, you're maintaining alignment with the bone, okay? It's not a reduction procedure, they're just maintaining alignment. Facet dislocations are a different kettle of fish. Okay? So facet dislocations is an active reduction process. It's like reducing a hip dislocation or a knee. You're not maintaining alignment, you have to do a certain maneuver or a shoulder to reduce it, okay? As opposed to just maintaining alignment. The cones go the same way, but you use them in a different way. Okay, so here's a rotatory subluxation, retraction. There's a displaced peg fracture. This, we put it in line, we line it up with a traction. What's this fracture? Oh, hang there. Remember, you got a step, anterior body line step, posterior body line step, spinal level line stay behind. The typical hangman's fracture there. And it's a hyperextension injury. It's called the force-south mechanism. Bump your head, you hyperextend and drives it forward, and you snap off the C2 pars. It's a hangman's fracture. If it's more than 3.5 millimeters translated, it means you've torn the disc, okay? And it's an unstable fracture that you put in traction. Over here, we've got a nasty looking, can call it a reverse fracture. It's a CF type 4. You've got obviously malalignment. The goal of traction is to maintain alignment. That's all. Okay. You can put them in a collar, but you know the Philadelphia collars before you know it. Next day you get pressure sores, raise the intracranial pressure. It's awkward. The patient often ventilated. You know, it's not a good treatment. These patients go to traction. You maintain alignment, frees up the airway, and it's a standard of care. This guy, you're going to put in cones, it's a dislocation, and you reduce it, active reduction process. You can't just put alignment and expect it to put itself straight, okay? This needs an active reduction process. Okay, so reduction restores can alignment and decompresses the cord. Time is everything. It's a very time-sensitive thing. We know that neurological tissue, the quicker you decompress it, the better recovery is. Okay, animal studies and clinical studies show early decompression promotes neurological recovery. There's various animal models from beagles to bunnies and all sorts of things. You know, swelling and so on. And the quicker you take the pressure of the cord, the quicker you can return to function. Convincing evidence in all the animal studies that cord compression is often a reversible form of secondary injury. As soon as you decompress it, your outcomes are straight away better. And in fact, we're thinking that the first hour is really critical, never mind 4 hours. first hours of the time to get it. So you must just, this is an absolute spinal emergency if you have a dislocation. Humans, we've got class 3 medical evidence that shows closed reduction improves outcomes. There's a statistical trial, which is a multi-centric trial, and the Americans, massive amount of numbers. And they looked at the ordinal change in age impairment, and they found that decompression within 24 hours has got improved neurological outcome. This is all injuries, not just cervical dislocation. Okay? So this doesn't really apply very strongly to what I'm talking about today, but it's just showing that the vast body of evidence says the quickly decompress the cord, the better the function is. So the sort of landmark article which will probably dictate today, but is Dennis Newton. He used to run the old Conwadi Care Hospital, and he treated rugby players. He had 57 rugby players. I mean, that's a huge amount. He seemed to have changed the game's rules nowadays. I guess the scrum, pausing and engaging, you don't see his injuries that often. You do get a couple, maybe about 4 to 5 a year. This is a huge amount. It's probably the biggest study I've ever seen. And he found that bifacet dislocation is a one injury which does benefit from early decompression. So these patients that came in Asia A, all came in Asia A, and they reduced within 1 hour, they ended up in Asia E. So Asia A is complete, eh? The guys examined as nothing. You pull them straight and they end up in Asia E. There's one recovered after 11 hours or so from Asia A to Asia E. And basically, he decided from his study that to get the best benefit, you want to do it in 4 hours. Okay, there's a lot of criticism of the study. The young patients, first of all, I mean, they're healthy, not like your average 50-year-old smoker comes in with a high injury. But there's nothing else we have in evidence that shows this is not the case. Okay, so you can't argue against it. There's very strong evidence for it. So, what about closed versus open reduction? Should we stay quicker to take a patient to theatre? Okay, so we know early decompressions, better outcomes. What about surgical reduction? You need an MRI scan before you go to theatre. You'll be lucky to get done within 2 hours. You can't even get hold of the radiology registrar after hours. Prepare the patient. You've got to call the sets in. There's a emergency board booked up. You've got orange cases. Now you've got to try and fit your case in. You know, you'd be lucky to get the patient reduced in 4 hours in theatre on a good day. I mean, that's just almost impossible. You can pull a neck straight, align it in 45 minutes. Okay, quickly. How safe is this now? Everyone's worried it's a dangerous procedure. So the Americans, they looked at it and they looked at all the evidence. 1,200 patients treated closed reduction, 80% of successfully reduced, and the reported complication rates less than 1% permanent neurological deterioration among 1,200 patients, all comers. A transient injury risk of 2 to 4%. So it's very, very safe. Okay. So closed reduction is the primary objective here. It's safe and effective. 80% of the time you're going to get it right. Do we need an MRI scan? I mean, is the MRI required? And there's a lot of this is very controversial among people who don't read or understand. Okay, so the pros, it gives you information about the spinal cord. You can see signal cage in the cord. You can see ligament injuries and so on. And it's very handy if you're doing a closed reduction. No, it doesn't work if you go to open reduction. It's nice to have. But there's no agreement on it. I mean, this is a study of 25 fellowship-trained spinal surgeons. There's no consensus whether you want a pre-reduction MRI or not. No one, they don't know. Okay? There's a lot of, everything's like worried about, you know, what if. What is a traumatic disc herniation? You all talk about this disc herniation. What is it? What is the definition? So it's defined as any disc which is protruding posterior to vertical line drawn by the caudal vertebra. So if it's sticking out beyond this, we call it a disc herniation, traumatic herniation. Most of the time, it's just been uncovered. The vertebra comes forward and leaves a disc behind, where it should be. It's uncovered. It's not a herniation. So this is the definition of a traumatic disc herniation. But that's also, it's very, there's a lot of inch-observer error. You can't seem to agree on these things. It also affects your surgery behavior. So patients that have a so-called disc at risk, you're more reluctant to do a closed reduction if you see the disc there. And that affects behavior. Now, I'm not worried about the disc there. I don't want to do a closed reduction, I'd rather go to theatre and delay me 4 or 5 hours to get to theatre. And that's a danger of doing an MRI scan, or one of the dangers. We also know that there's a study that showed what does a disc do during closed reduction. So 18 patients had pre-reduction disc herniation, if you describe it as the disc posterior to the vertical line. After reduction, 56% had disc herniation, so it's more, but no patient deteriorated. So it doesn't have a clinical significance. It doesn't really matter. Here's another study, 85 patients treated, 62 light MRI, no deterioration. And we know 1,200 patients, and a large volume of these will have a disc herniation. Less than 1% got worse. So it doesn't really matter if it's a disc herniation or not. We know that you've got a 99% chance to make no difference whatsoever. Why is it so low? Why is it such a safe procedure in spite of having disc herniations? Okay, we accept as a high incidence herniation. We know neurological deterioration is very rare. It may be the traction itself is protective. So instead of just putting a neck back straight, the traction is somehow helpful. And there's been some biomechanical studies pulling this back. Somehow it seems that the traction reduces the disc instead of just pulling a neck straight back. These guys show that the canal ratio improved after traction. And it's different theories. So the theory is when you pull, it somehow pulls the disc back and prevents it sweeping into the canal. I think this is pretty simplistic. If you just pull it back with the right traction, you may sweep the disc in the canal. And we know that if you do it under manipulation and anesthesia, you're going to paralyze the patient. So don't do it asleep. The patient's going to be awake. I think it's too simplistic. The reality is, when you have a dislocation, this disc is very strongly attached to this inferior body. It's just been uncovered. It's basically pulled off the cephalate vertebra, but it's very strongly attached here. And you have to use a cob or a strong instrument really to peel it off. It's not like you can pull it out. So when you put traction on, you're just impacting this. This thing's very stable. It's not going to sweep back in the canal. And I've also done a cadaver pressure study. The damage is not coming from this disc corner. The damage is coming from this body corner. So there's other reasons for the cord injury. MRI is risky. It delays treatment. You've got to take the patient off a trolley, put them into the MRI scanner with an unstable dislocated neck. Time is running out. And it also sways you from doing a closed reduction, 15, 20 minutes, to go to theatre 4 hours later. So a lot of reasons not to escape. It's not only us have delays to MRI. This is a study 4 days, 5 hours. Australians also struggle with in the rural areas to get MRIs in 11 hours. This is American supplement from the neurosurgeons. You sometimes listen to them. They find that the use of pre-reduction MRI has not been shown to improve safety or efficacy of closed reduction, and it may unnecessarily delay spinal column realignment for decompression. Okay, so this is from all the available body of literature. So you do not need an MRI, or in fact, you don't want an MRI before reduction. Okay, so we've also got a very unique problem in South Africa, Constitutional Court. Playing now, see. Play. Pretty. Yeah. Just to show you how dislocation works. So this patient, Mr. Oppold, he had a neck injury, 2002, was taken to West Kruger Hospital into Kruger Closed. And of course, we didn't do reductions those days. It's spinal cord, goes to Conradi. Eventually went to Conradi and was reduced after 14 hours. Okay, so he ended up quadriplegic. He then instituted a delictual claim in the High Court, and he claimed that they were negligent for not reducing his neck within reasonable time, within 4 hours. I don't know how they heard of Dennis Newton paper in those days, but they got hold of it. And this is paper. And then, so Newton concluded that patients with bifacet dislocation have got a 64% chance of a complete recovery if it's done within 4 hours. That's pretty convincing stuff. And he said that Oppold would not have been quadriplegic had it been done within 4 hours. The High Court found that it was reasonable. He found that delays were unreasonable. He found that the equipment's cheap and it's an easy procedure. Why the hell would we do in Kruger Closed hospital? And the water damage to Mr. Oppold. The Department of Health then appealed to Supreme Court of Appeal, and they found that he didn't prove the validity of Newton's argument, and they reversed the High Court decision. Eventually ended up at the Constitutional Court, which then ruled for Mr. Oppold again. And they found that the Department of Health's failure to treat him rapidly violated his right to emergency medical treatment. And he's awarded 19 million rand back in 2015. Okay? A lot of money. Found that the proper treatment's inexpensive and could have been performed promptly. I mean, you can't argue that. Okay, so the High Court in the land has agreed that low velocity cervical dislocations or low energy must be reduced in 4 hours. So we haven't actually come to the point of arguing whether someone's got a facet fracture, is it high or low energy, or is it a car accident? Did the dislocation happen during a low energy part? I mean, we don't even got that argument, but don't even get there. Just do it as soon as you can. And the problem is this law doesn't take into account resource. I mean, you've got a trauma unit full of people dying of multiple injuries, polytraumas. Now you've got to prioritize the neck dislocation because of the court ruling. It's also a little bit unfair, but what they want to probably see is that you made an effort. You haven't just left the guy on a stretcher, or do later, or do tomorrow. You've at least made an effort to put in cones calipers, make a reduction. Doesn't need theatre, it's cheap, inexpensive, and anyone can do it. Okay, so what are today's reductions? So from the accident to hospital ER, from the hospital trauma referral to the specialist, and from the specialist being referred to reduction. So in Australia, these guys are getting reduced urban areas 10 hours, 27 hours in rural. And that's Australia, sort of first world country. So it's huge amounts of distances to travel, and everyone's not willing to touch these injuries. So they looked at the waiting time for MRI, 5 hours. I mean, the same as us. Target hospitals found that the ambulances are pretty quick in the Western Cape, 3 hours from injury, average time, 3 hours to get to the guys to the ER. ER, of course, took 14 hours to refer to orthopedics, and orthopedics took 14 hours to reduce it. So there's lots of time you could save in this picture here.
28 hours.
Eh?
28 hours.
Yeah. So we've got an SOP here, and our best time is probably an average of about 10 hours with the SOP on the board in trauma. So it's very hard to change the perceptions and mentalities. So there's a lot to do in 1 hour. So if your average ambulance arriving time is 3 hours, you've got 1 hour to sort this out under the Constitutional Court sort of thing. Get the patient history, examine, find your stuff. I mean, that's also a bit of a story in its own right. The nurses, where's the stuff locked up. Find your double mattress, C-arm, a whole lot of stuff to do. Okay, so anyway, point is these are court-saving procedures, and it is very feasible to do it. I mean, the court's going to say, well, that stuff should be in a cupboard locked up. Why could you not have it available? How can you do? You can't defend it. Okay, so quickly about reduction for dummies. First described in a long time ago. Crutchfield brought his tongs. So there's a whole bunch of stuff we've got available from the Crutchfield to the cones calipers, Gardner wheels. This is a halo. I've used a halo before. If you see this, throw it in the bin. Doesn't work. It's actually I'm not actually sure what it's used for, but it goes right in the vertex. So you can see the way it grips. It will pull out very easily. You actually got to drill a very deep hole into the skull to get those pegs into it. I don't even know if I've seen them around somewhere. I've never seen them used, hopefully, but yeah, it's called a Crutchfield Tom. So it's really poor. This is a Rolls Royce. Gardner Wells is the stuff. This is the bee's knees. This is what you want. I ordered a couple for the hospital. We mostly have these cones calipers, which are really not good, but you can make them work if you put them on properly. And unfortunately, I grew up with the cones calipers, and I'll talk about how to put them on properly. But you've got to put them properly, otherwise it's going to be a problem. They retail for about 15,000 Rand, this piece of rubbish. Gardner Wells again for about 7,000 Rand, okay? Straight from Germany over alles, okay? These are really good. If you can get them in the hospital, that's what you want. Okay, so we'll talk about cones calipers. They come nicely packed. We've got a couple of components. You got the pins, which don't always match because the people on the CSSD just see thick and whatever, but make sure pins fit the barrel. They might be too long or too short. And you've got a nut at the end with a spanner. You can never find spanners, but apparently they come in a spanner to open and close it. And it's like a scissor, so you open the back, you can close and open the cones. You come in a variety of barrel shapes, and once again, your pins may not always fit the barrel. You might have a pin for a long barrel with a short barrel, it's 6 side 2 centimeters, which you don't really want. Your pin's got a thread which goes in the barrel, and this is a square nut where your spanner acts like a key, and you can turn it in and out. So you want to have a pin. You want about 3 to 5 millimeters of pin in the skull. That's your grip. And you turn your pin until you can see how much is protruding, and you want about that distance, 3 to 5 mils, not more, not less. There's a spanner, you can see a little hex nut which turns the pin, and by spinning it, it will spin it in. To do close reduction, the patient's cooperating with you. You need him to monitor his spinal cord. He's a neuro monitoring. Wait, cooperative patient. You can't have a drunk guy, unconscious. And he's going to do your monitoring for you. Put up a SATS monitor, maybe BP cuff if you want. And I'll put there, this is the official standpoint. It can be performed by an experienced clinician who is a heightened aware of potential complications, okay? Look, in an emergency, any doctor should be able to do this. We expect to do intubate a patient, do a chest drain, do all sorts of stuff. This is a very simple cord-saving procedure. Contraindications, you need a diagnosis, so you must make sure you know what you're doing. You can't have an unconscious patient. Skull fracture is a relative contraindication, depending where it is. So, skull fracture top here doesn't really matter. You're putting it lower down to the petrous part of the temple bone. But obviously, a skull fracture patient is probably unconscious anyway, so you can't do it. So, but if you've got a wake patient with a small little fracture, doesn't mean you can't do it. Infection or degloving of the scalp, I haven't really encountered it yet. If I've got a dislocated neck and I'm quadriplegic, I don't care about infection or scalp degloving. Stick it in the bone, pull it straight. What do you need? A bed and double mattress. You need a C-arm because you need to monitor under X-ray or your progress of reduction. And you want calipers and tray and stuff, SATS monitor and some sedation. So there's equipment. You want your orthopedic rope. You want a swan neck pulley. So the point of this pulley is that you can raise it and lower it. That's why it's got a long swan neck. Big problem with these pulleys is that besides not having enough of them, the beds have changed. And they don't all fit in new beds. That's a massive problem. You need a weight, a spike, weight spike for your weights, a couple of weights, and a bed. These weights disappear very quickly. They're very attractive to sell, so they're often missing. I've used pillowcases full of drip bags before. Weight, you can use whatever you like. It just becomes very big and bulky. You imagine 50 kilograms of water, or you can use, there are commercial water bags, I suppose you can use as well. You can make it work, but ideally you want the weights, swan neck pulley, and proper strong rope. Okay, so the positioning next supine double mattress, and you may want to tilt the bed. Why do you want a double mattress? It's not for pressure source, not if you want a soft landing. The point of the double mattress is you want to have the option of extending a neck if you want to, okay? So when the neck's reduced, you want to have an extension. Now, normally Oxford puts you forward a bit, so you're going to have the body slightly higher so you can drop there. That's why I have a double mattress. Okay? You may want to tilt the bed, reverse Trendelenburg, because then the body weight acts like a counterweight. Because you're pulling quite hard. And you're going to be pulling up to 45 to 50 k's, the body will just follow that. So you want to be able to lift the head of the bed up, body acts as a counterweight. Or you can strap the shoulders down, which is another option. But usually the body as counterweight is fine. Shave the area of the head, clean the IV and inject some local anesthetic. So this is your landmark, and this is so simple. You cannot get this wrong, but yet we have got it wrong. Your ear hole is in line with the spine. Okay? So you're going for the ear hole. That's the line of your spine. You want to be in line with that. And anywhere that line is fine. Obviously, the higher you go, more likely the pin's going to slip off because you're now above the equator of the head. The lower you go, you're in the ear. So give yourself some space above the ear. Put a finger there and just go above your finger. Really so simple. Nothing difficult about this. You don't want to be over here. This is not a good area. This is your temporal muscle. There's an artery in here. It's soft bone. Just squamous part of your temporal bone. The pin will go into your brain. Over here, you've got a nice thick bone. It's your petrous part of the temporal bone. It's about 1 centimeter thick, 2 centimeters of registrars. Lots of space there. Okay? Can't go wrong. It's not sore. You bite down. You feel it. There's no muscle here. So the technique, so you shave the area, you put your Marcaid or the adrenaline straight down the periosteum, okay, inject it, lift it up and raise the bleb. So you've got to mark where you're going to go. And you make a little stab incision, vertical incision, okay, you want to try not to for the artery, a little vertical stab, and you put your pins on, okay, it must be symmetrical as well. Okay, so you can also palpate the artery. I mean, you shouldn't have to palpate the artery. That's miles in front if you're in the right place. Vertical incision. So if you're using the calipers, that barrel is sitting on the skull. Okay. So you take your artery clip and blunt dissect down to periosteum. There's less bleeding than trying to cut straight onto it, and it gives you space so your barrel can sit in the skull. That's a bit too far forward, eh? It's almost looking around the maxillary arch. So you want to be here in line with the ear hole. That's where you want to be. It's too high. It's above the equator of the head. Okay? Why do you need to be so high? That's where you want to be. In line with the ear hole, which is in line with the spine. Look at the skeleton around about there. Okay? And the point is, this barrel of the pin is sitting on the skull. Just the pin penetrates. If the barrel's not in the skull, the pin's not in, it'll slip off. How do you get the pin to penetrate the bone? So you drill it in. You can tighten the nut in the back, which will tighten the pin on the bone, but it will never push it into the bone. The bone's rock hard. You can tighten all day long. There's enough flex in the system. It's not going to push the pin in. But you tighten it so it's in tension, you spin the pin backwards and forwards. Okay? So by spinning this pin backwards and forwards under tension, it will cheese wire into the bone. Okay? And when it's in, it's in. That's where you want it to be. So this barrel, here's the skin, the barrel is through the scalp on the bone, just the pin penetrates 3 to 5 mils. When you've got it on, you must take the head and you must pull as hard as you can, make sure it's on, before you put the weights on. Once the weights are on, you get 40 Ks and it slips. Let's keep going. You shouldn't have to pull it with your hands, please, okay? That's only with the cones calipers. I want the models of the Rolls Royce, you don't need to do this. Okay, then you apply your weights, the pulley and so on, and you get going. See any problems with this x-ray? Yeah. Barrel's not on the skull, eh? Pin's barely denting the periosteum. That's going to slip off. Another one. Look at the pin here. It's totally wrong. Pin size of the barrel. I mean, it's like not even in properly. This is a disaster. There's a patient got a pressure sore from the pins ripping out. This one is through the zygoma, I think, or a facial nerve. This one slipped up. Okay, this is going to not put in properly. This is a horror show. This is my favorite. What's going on here? Okay. Patient's crying in pain. Okay. How much weight do you put on it? So there's no documentation how much weight. I can tell you though, to dislocate a neck, and an old tiny cadaver neck, I used a boat winch, it took me 400 kilograms. That's the power of these ligaments. So we ballpark, I'm going to stop you guys at 45 kilograms. Okay? If you haven't got it reduced by 45 Ks, it's probably not going to reduce. Okay? We'll talk about fail reduction. Dennis Newton used to just put in 50 Ks, boom, and go. And I hear by the grapevine, some patients got worse than that. It's probably not, you don't want to go so big. So I've got a safe way of doing it. But in general, you're increasing weight until your facets are reduced or something changes. The patient starts using neurology or over distraction, or you can't put more weights, or you think it's failed. Okay, 45 Ks is about your target weight. How do you do it? Start at 5 Ks. Now you've put in a weight. You want to see what's happening. Are you over distracting? Do you want any surprises? Okay, so start at 5 Ks. Take an X-ray. Now you need to flex a neck. This is really important. People don't flex a neck. Why are we flexing it? Yeah, so this is a great example. Look, it's a real neck. Dislocate it, and you can see if you pull it, it won't go, it won't reduce. So, okay? It won't reduce. You flex it, the facets jump. Okay? It's like a cross run. It's like a periosteum in a kid. The kid's fracture to make it worse to get it on. So the anterior check ray, the soft tissue, the muscles means you have to flex it to allow the facets to hook on. Okay? So 20 to 30 degrees is a safe flexion. Remember this neck, to get that to dislocate, the guy's chest is probably hit his belly button. Okay? The order of 20 degrees of flexion is nothing compared to what that neck's been through to cause a dislocation. And you're going to increase now how much weight you put in. This 10 pounds to the head, 5 per level, I mean, who works in pounds? There's all these bizarre, very historical measurements. Make it simple. Start at 5 Ks, increase by 5 Ks every 5 minutes. Okay, it's really simple to remember that. And every time you increase weight, take an X-ray, do a neuro check. Okay, target weight 40, I put it at 40 to be safe. Target did a study in their device and they found most reductions occurred about 35 kilograms if you got adequate flexion. Okay, 40 Ks is safe. I've been to 50 or 60. Your pins are good, they're not going to pull out. Okay, pins will definitely take probably 100 kilograms if they're in the bone properly. Okay, so here's a neck. This is a reason for flexion. If you just pull it straight, the periosteum and the ALL acts like a check rein. You can't pull it straight. But if you flex it, it gives you a bit of slack in the system, and you can get it hitched over the top. Okay, it's as simple as that. Once you got reduction, extend the spine, drop your weight down, and check an X-ray. Okay, so in summary, start your reduction, you add in 5 Ks, start 5 Ks, neuro check X-ray. Flex to 20 degrees. 5 Ks every 5 minutes, neuro checks until your facet is tip to tip. Once it's tip to tip, you want to extend the neck. So this is why I got a sore neck. This becomes, this is what this whole process is about. So remember, when you start at 5K, the tension is 5 kilograms. It's not enough to hold the head up in the head flexion. It's sad. So put some pillows underneath the head to hold it up. So you've got your 20 to 30 degrees of flexion. But low weight, you need to have something under the head to help you. As you start increasing weights, 30, 40K, it can be really tight to pull it. Then your pulley is adequate to hold it in place. Okay. Now, when I'm doing my x-ray and I see my facets are now not dislocated, now tip to tip, I know that if I extend it, I can reduce it. But then I do, with my weight on my 40K, I do this clamp, and I drop the pulley down, so the facets are now where they should be. Then I take the weight off. Okay, down to 5K. What's the end point? The end point is reduction. Will the patient get worse? Less than 1% chance, eh? Over distraction x-rays, I think I've seen it once ever, or failure of reduction, okay? You might fail to reduce the neck. Minor failure, it's a pin slippage, the most common reason. Neurological deterioration, less than 1%. If you reach a target weight, 45 Ks, we might decide clinically you're not happy or uncomfortable. That's reasonable, okay? Okay, so this is my failed reduction flow diagram. Pin slippage, very simple. Take the weight off, put the pins on properly, do it again, okay? You need to get the neck reduced. Don't give up because your pins are slipped. When you reach a maximum weight of 45 Ks and not reduced, well, why is it not reducing? Usually it's not enough flexion. So check you've got adequate flexion, okay? If it's still unreduced with adequate flexion, then it's a failed reduction. If you decide to abandon the procedure because it's just, you're not happy, or the planets aren't lined up, it's fair enough, or the patient deteriorates, you've got to abandon the procedure, okay? What do? Take the weights off, tie the collar, give oxygen, keep your blood pressure mean up, patient goes for surgery. Really simple. Okay, so complications, there's loads of them, from fracture to making dislocation worse, pin slippage, GA, high mortality. So you don't do under GA. You can sedate the patient, a little bit of dormicum, 2 milligrams just to take the edge off, and a bit of morphine for pain control. The patient's got to cooperate with you. Eh? That's why it's safe, because the patient's your neuromonitoring. It's very safe. This is 1% worse in 1,200 consecutive patients. All comers. Okay, so there's a dislocation. You can see it's a unifacet because there's 2 facets fully aligned. There's one touching a tip there. There's a bow tie. And you put in your traction. There's a flexion, nice flexion going on there. Under traction, the facet now sort of looks like it's tip to tip. You extend it, drop it down, and you decrease the weight. Now, remember, the double mattress allows the extension. Once a patient's reduced, they're always going to be slightly unstable. It's a discal ligamentous injury. They won't stabilize. You've got to fuse it. But then if you've done that night or as an emergency, they can wait for the next available time, the next week. Doesn't matter. The cord's decompressed. Okay? You've done the job. This can wait until a more attractive time. Or the patient's periphery, you can then transfer the patient for surgical stabilization. So, helping reduction, a bit of sedation, flexion, really important. Also, sometimes, the patient's got no neurology. You've got more time in this. You can leave the patient a couple of hours within their traction. Gradually, the patient starts fighting, relaxes, and facets jump over. We used to leave the patients in trauma for quite a long time while you're doing cases and things. You come back and check on them if you have time. Obviously, the guys with severe neurological deficit, you want to do quickly. 5 Ks, 5 minutes. You go. Don't extend the spine until the facets are tip to tip. If they're not quite over, they're not going to be able to go down if you extend the neck. They must be at least tip to tip. And also sometimes you get C7, C7, T1 or fat neck. You can't really see the dislocation. The oblique views are very helpful to see. Take a 45-degree oblique and you can see the facets beautifully here. You can even see it's a unifacet. You can see they're all nicely lined up like tiles. So the oblique view allows you to see that cervical thoracic junction, which you normally can't see in a true lateral. Okay. Okay, so who needs to be able to provide, who needs to be able to do it? The ER doctors, neurosurgeons, orthopedic surgeons. So I consider it a skill set for all doctors. If a patient comes in with severe deficit or deteriorating neurology, you have nothing to lose. Nothing to lose. Your urgent closed reduction. Okay, so the key points: make a diagnosis, early alignment, imperative, closed reduction is the prime objective. Don't do MRI. You have a constitutional court ruling, less than 4 hours, and these are court-saving procedures. So how good are we in the Western Cape? I've done a survey, did it again this year. We did a survey monkey of all the Western Cape hospitals, and most places don't have protocols for doing it. They don't have equipment, no equipment in the hospitals. Most people haven't had training, even though we teach all our medical students, they seem to forget. They don't understand. Okay, so 80% do understand the right indication to reduction, but only half would actually do the reduction if they have to. They'd rather send it somewhere else because the way is dangerous or so on. They feel that only 10% think it's safe. Most people think it's unsafe, and that's clearly not the case. And that's maybe the reason why people perceive it as being an unsafe procedure. Most hospitals don't have specialists available to help out, so you're relying on the junior doctors to do these procedures. And most people found they would change their clinical practice if they had adequate training. So hopefully this counts as adequate training. No. So there's misconceptions, it's a dangerous procedure. You know it's not dangerous. It's safe and effective. Misconceptions, you need an MRI scan. You know you don't need an MRI scan. And all the literature shows that you don't need an MRI scan. It delays things. And is it a special procedure? No. We teach it on 50 level. In fact, I did a study published in SOJ looking at specialists around the country, and most specialists don't know how to do it. Okay. So the average orthopedic consultant or neurosurgeon cannot do reduction. The WHO actually considers cervical traction one of the essential skills for a district hospital. So it's not just my perception, it's a WHO requirement, and it's a district hospital procedure. So it's emergency equipment. Every ER needs a set of Cohen's calipers, and every ER doctor should have the capacity to do it if necessary. So look, if you're in a peripheral hospital, you got a guy coming with a jump facet and he's normal, I don't mind them discussing with us, say, phoning, asking, say, listen, I've got this, what do I do? Ambulance is ready to go. I'll say, sure, bring him over. But if it's an AJ, a quad, you do him right there on the scene. That's when you want to do it. That's the one case you don't want to put in an ambulance. Send across. Okay, so let's get about that. Okay, thank you. You maybe show a few x-rays for the clean beans. Responses? Diagnosis? Treatment? No, it's displaced, eh? It's unstable. So traction and it's going to be just alignment, eh? That's fine. Simple as that. Maybe you can see it there.
Yeah, I just see it.
There's some overhang there. So I haven't measured it, but it looks like it's unstable. And if you do a CT, you can sometimes see a flake of bone where the ligament pulls off the inside. And that's quite helpful if you're a flake of bone. It means that with traction and alignment after 6 weeks, that flake of bone can reattach and you'll be stable after 6 weeks. Danger is no flake of bone in CT. You put the guy in traction for 6 weeks, the ring heals, but there's still no chance of ligament. So after 6 weeks traction, In fact, after 3 months, because 6 weeks traction, 6 weeks collar, you do flex exfuse to check if there's no instability. Yeah? That looks like a stable injury. I don't know what's going on there. Dan, what's going on here?
C4 facet, I would say.
Yeah, so it just looks like it's subluxed. It looks like it's loss of alignment in the back here. It's less than 50%. But what's this condition? I mean, there's coalition here, or it's like a wax candle appearance.
Yeah, dish or angstron.
Yeah, it's dish or angstron, and probably dish. These are highly unstable injuries. Long lever arm. What would your treatment for this one in emergency in the ER? Is it Asia C?
Well, ideally you need further imaging because these guys have a high chance of contiguous or non-contiguous lesions.
Okay, so MLS is fine with outlet injury.
I don't know an answer, but I would proceed for reduction in Cohen's.
Because the CT be helpful to see are the facet fractured or the shear type injury. It looks like a piece of chalk. So, but this is not a traction reduction process. This is just put alignment on this sort of injury. It's not a normal low energy facet dislocation. This I just put 5 Ks in alignment, watch him resuscitate his cord, the inotrope, and that sort of thing. Okay. But you want to establish alignment. He's obviously malaligned here. The collar won't help with it. Francis?
Yeah, so this one, simply really fast, one is purged, there's a little piece of the back that might cause facet fracture. So, yeah, so he's going to fall out of the leg.
No, this is a dislocation. I think there's nothing above here, so it's probably a bifacet. Eh? Normally the unifacet, I mean, maybe tip there, maybe push.
It's about the
Maybe. Okay. This one has a reduction process. Eh? This one goes in traction, flexion, the whole thing. Okay, good. Vision.
So there's a facet fracture application. 7.
Okay. 6, 7, fracture dislocation. You appreciate there's a posterior element fracture here. Yeah? This is probably not one the court will frown upon because this is a fracture dislocation. Eh? But you want to still put your emergency care in fairly early. So what would your treatment this be in the ER? Now you got an unstable spine.
Or just going up by line and east.
Yeah. Fine, just be very mindful of this one. There's a lot of distraction in the back. Eh? There's a big gap in the back. And this is one I'd be very worried about hyper over distraction. So this is probably one you want to maybe manage in a collar and not rush. I'd be worried about this gap in the back. That's only sort of particular.
I guess like that is the perhaps like we need to do some kind of like action view and where just need to see like this got a straighten up before you make that clear.
Well, you can maybe put 2 Ks on and just see. You can just be very mindful of it. Eh? So if you're going to put 2 Ks on, just take an extra and have a look. But more you want to extend this neck.
Yeah.
You just want to put an extension. That'll be probably good enough. But you don't have to do traction. He's already distracted. So what's traction and help? This one is going here. Cindy.
Flexion compression type injury.
Good. See it. Well,
And it is
you appreciate this.
C3.
This body should be lined up with this one. So
Yeah.
3 or 4. Eh?
C3 flexion teardrop injury. It's dislocated as well.
Oh, no, that's not. It's just, yeah.
It's not dislocated, but there's quite a severe kyphosis.
Yeah. Transcalipers, yes, no?
I want to reduce it, yes. Yeah. So you think it's used.
So how are you going to do a reduction process or just alignment?
So you just want to extend them to align them.
5 kilograms in line, maybe slight extension. That's all. These guys, this sort of injury, a CF4, I mean, his cords, he's probably an Asia A. So you just maintain the spinal alignment here. This one. Dislocation, I think.
Dislocations.
Well, look at the body, it's obviously dislocated. What type? Unifacet or bifacet?
Facet.
Ah, it's 150%. It must be both off, eh? Or you've got a facet fracture. This one has your reduction process, eh? Simply put this in traction, it's not going to reduce. You have to flex. I can see the model getting the facets over. Use the back there, you can help you. Use volunteering arms here. What's on this one?
Oh.
Old. Yeah, it looks like a chronic peg fracture. I wouldn't bother putting traction onto this one. Unless the guy comes in myelopathic, it's got a cord signal, then maybe traction will help aligning because he's subluxing off. That may be indication, okay?
And this is one where you'd be happy to do an MR first.
Absolutely,
No rush.
absolutely, no rush. Yeah, no, absolutely. Look, the hassle with MRIs, you've got to take the calipers off to the MRI scan. So just be, yeah, just think your timing in there. I can't really see, but looks like a fracture there. I think as a CT scan. This one clearly just spinal alignment, eh? Cones, calipers, alignment, that's all. Would you worry about this disc being reduction? No, not at all. Don't even why he's MRI scan. So the same patient. Facet fracture dislocation. So when you're going to facet fracture like that, sometimes they do block you. I don't know why, but seem to block your reduction. Sometimes you can't always reduce. So if you've got a facet fracture, you still try your reduction, but don't be too surprised if you fail. It might be that one of the 20% that do fail tend to be the facet fractures, and I'm not sure why. I think sometimes the facet disconnects from the body and acts like a block. I can't believe it was chip lying there causes a block. But it is. If you're a facet fracture, often they are high energy injuries and they do block you. This guy looks like a flexion, incomplete teardrop, 2 levels. Once again, just alignment, eh? Traction with alignment. And you're going to extend him, you're going to put a bolster on the back of the neck to try and align his neck. What's going on here? Okay, can you see?
Not very clearly, but there must be something at egg level.
Yeah, good. So when you look at the peg, it's a bit vague here. So remember the back of the C2 should be a straight line for the peg. So the peg unit, if he's sitting like that, eh? The other thing you can see is that this arch is of C1, look at the spinal linear line. It should follow there. This is now way back. So the whole peg at C1 is now fallen back, okay? How are you going to put this one? Align this one.
This one's the inflection is reduced.
Like, yeah, so I think traction, but I wouldn't rush reflection. I'd put it in line and see what happens. That's probably all you need. If you think in inflection, then you can adjust it. Your default's in line. I almost never see some flex, but you obviously might adjust it depending what it looks like in X-ray.
I thought that one looks like a C1's almost fused to the.
No, I think it's just the fracture. It's a cute one. There's the top of the peg that's missing, so the whole of C1's come back. Okay, what's this one? So your antibody line concept is okay. Antibody line is fine. Your peg is a line, not a peg fracture. Look at spinal level line. It's fine. Go there. See one's come forward, eh? So what's happened here?
Probably
So this is disconnected, the fracture here. Okay, so this whole component is one has come forward and left your posterior behind. It's hangment. How do you treat that? Traction in line, and you extend it. Okay. There's another one there. Another hangment. Nice gap. If it's more than 3.5 inches of translation, means it's definitely forward and it's unstable hangment. Yeah? Also, when you put them in traction, you want to push the C2 forward to close that fracture. It doesn't help just putting head extension because they may just rotate at C7. You want to actually push C2 forward to close the fracture down. Okay, I'm going to out now. Any questions?